Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, your host, and Healthline 3 is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering your questions live in the studio today. We'll be opening those phone lines soon, but as a reminder, make sure you're in a quiet room when you call with your TV turned all the way down so that we can hear your question. Our number is 318-219-4569. That number will be on your screen. And today we are talking about coronary artery disease, screening, prevention, and treatment. Joining me today to talk about this is Dr. Bob Martin with Willis Knighton Piermont Cardiology. Good afternoon, and thanks for being here.
My pleasure. Glad to be here.
Absolutely. So you are a cardiologist, and you typically, you're going to be treating coronary artery disease. This is a pretty big disease that's prevalent here in the United States.
Correct, right. Correct. So coronary artery disease is widely prevalent in the United States. It's the #1 killer in America in both men and women. And, there's a lot present locally, and we see a lot of folks.
Mm-hmm. Yeah. So what exactly is coronary artery disease? Can you explain that?
Yeah, coronary artery disease is where the cholesterol gets into the blood vessel wall, the arteries that carry blood to the heart muscle itself. And atherosclerosis is probably a bigger process, and that just means that any vessel in the body, any artery in the body that has cholesterol building up in the vessel wall can be affected. So if it's in your legs, it's peripheral arterial disease. If it's in your carotid arteries, it's cerebrovascular disease. But when it's affecting the arteries that carry blood to the heart muscle, that's what we call coronary artery disease.
Yeah, thanks for clearing that up, because I think sometimes you can have heart disease, but it may affect you in different ways, correct? Or you could have presence of atherosclerosis, but it may not technically be coronary artery disease, correct? It can happen other places. Okay.
Heart disease would be kind of an umbrella term, and heart disease can involve weakness of the heart muscle. It could be valvular heart disease, where the doors in the heart that direct blood they're not opening and closing well. It could be electrical problems of the heart, cardiac arrhythmia. But when it's the blood vessels themselves, or the plumbing, if you will, for the heart, then that's what is coronary artery disease. But those would all fall under the umbrella of heart disease.
Gotcha. Well, and it's important probably to identify where it's affecting you so you can have the proper treatment.
Exactly.
As well. Okay. So it sounds like this is something that happens over time. It's not like one day you eat something or you smoke a cigarette and then the next day you're like, oh, I have coronary artery disease. This is something that's chronic.
That's right. And we've learned that it begins in our teens probably. And so in autopsies done on fallen soldiers who are in their early 20s, the presence of atherosclerotic coronary artery disease, the buildup of that cholesterol in the blood vessel wall has already started. And so it's choices, some of it's genetic, but some of it's choices we make as young people that become detected as middle-aged people. Maybe start having symptoms, or it's detected in our 40s and 50s. And then it may have a stranglehold on us by then. And so we need to be thinking about these things earlier and earlier.
For sure, yeah. So let's say someone is in their 20s or 30s and maybe they are curious. Is there a lab value that someone can get to see, the status of where their cholesterol is? I mean, I don't know if that's a good measure for, predicting where you're going to be. Like hopefully, if you have lower cholesterol, will that prevent you from getting coronary artery disease?
Yeah, that's a great question. And so, most people recommend that their cholesterol be checked prior to them ever leaving their pediatrician's office. So it's recommended to have a baseline cholesterol by the age of 18. And some people have genetic problems and they process cholesterol differently, and they're predisposed to early onset atherosclerosis in this process. And so it needs to be checked early and treated if you're one of those. But most people, if they're in their 20s or 30s and they have risk factors for coronary artery disease, getting a baseline cholesterol assessment is good, and if they have a family history of heart disease, then certainly by the time they're in their 30s, they should see a cardiologist.
Yeah, okay. And so you mentioned this is the #1 killer for men and women in America. So who is at risk? I mean, it sounds like everyone, if it affects men and women, but who may be more at risk than others?
So the risk factors for coronary artery disease, there's about 8 or 9 risk factors. So men are more at risk than women. So being a man or a postmenopausal female over the age of 50, having high blood pressure, sugar diabetes, elevated cholesterol, a smoking history, a family history, genetic predisposition, or being past your ideal body weight or inactive.
Gotcha. Okay. And you mentioned postmenopausal women, and that's because of the estrogen. They lose the estrogen production after that. Is that correct?
That's right. So they're somewhat protected early on, but the rate of coronary artery disease once menopause starts is actually greater in women than it is in men. So
wow.
There's acceleration.
Yeah, okay, good to know. And that probably happens, after the age of 50 is what you mentioned. That's another risk factor. Okay, so what would you say is the easiest, well, it depends on the person, I'm sure, but one of the first things that you start on was a cardiologist, like let's focus on this risk factor in particular. Which one would you start with?
Well, I think that, generally we need to be healthier individuals and make better choices. So, like I said, some of it is genetics. It's the hand that you're dealt, right? You can't pick your parents, right? You get what you get. You get what mom had or what dad had. You're set up for some of that. But a lot of choices we make, right? We decide what we're going to eat. We decide if we're going to smoke or not. We decide if we're going to be physically active or a couch potato, right? We're going to decide, a lot of those things, whether we smoke, any of those things. So those are choices that we make, and we start making those choices as teenagers and young adults. And so we need to have an understanding that those choices have consequences, right? Decisions have consequences. And so, the earlier that we can tell people that, cigarette smoking's bad or vaping's bad, those kind of things, or that, hey, we need to, make a better habit of eating vegetables and whole grains and, less fried fatty foods, those kind of things, then, that's a foundational a lifestyle for less cardiac disease.
Right, yeah. And so you mentioned in the 9 risk factors, sugar diabetes. Are you talking about type 2 diabetes?
Type 2 diabetes,
okay.
Yeah.
And versus the type 1?
Well, all diabetics are predisposed to coronary artery
Okay.
disease. Sugar diabetes is just an old Caddo Parish influence on me, I guess. That just resonates with patients a little bit more.
Right, and the more, I guess, blood glucose or blood sugar that you have floating around in your body, the increase in inflammation, which I guess could increase your risk for.
That's right.
That's kind of the reason why.
We believe the trigger for atherosclerosis, or the buildup of cholesterol in the blood vessel walls, is due to inflammation, and much like the cholesterol and the blood glucose, I mean, it's just marinating your blood vessels and your organs in the syrup, if you will, of diabetes, or the cholesterol, the fat, if you will, for coronary disease.
Yeah, that's a good point. I like the analogy there, the syrup, marinating in the syrup. I like it. It makes sense. So what are the symptoms feel like? If someone, like they're over 50 and this has progressed for a long time, what do those symptoms feel like for that person?
The classic symptoms, that we were taught in medical school, it's a 50-year-old man who has exertional precordial chest pain, a heaviness, a tightness. He feels like, a brick is laying on his chest, and the discomfort may radiate into his neck or jaw. He may have shortness of breath, nausea, become diaphoretic or sweaty with it, and then stopping his activity, the symptoms resolve or lessen. So that's the classic symptoms. But coronary disease can be a lot more subtle than that, and we have there's a lot of women with coronary artery disease, and they don't have those typical symptoms. they can just feel short of breath or tired or feel like they don't have the energy that they'd had in the past. It's very subtle. They can have shoulder discomfort, scapular pain, and it can present in a variety of ways like that.
And you're like, oh, I'm just getting old, just kind of brush it off. So it's easier to probably brush off as well. Well, we have Amber on the line. Amber, thanks for joining us. What's your question for Dr. Martin?
Hi, Dr. Martin. My grandmother has an upcoming heart cath, and I just had a question about placing stents. Somebody mentioned about image guiding placement. Is that something you can explain to me?
Well, that's a deep question, but so when someone is undergoing heart catheterization, that's a test where we go in through either the artery in the wrist or the artery in the leg, and we put catheters up to the heart and we shoot dye in the blood vessels around the heart and look for blockage. And based on the severity of the blockage, the location of the blockage, and the other medical problems that the patient has, we have to decide what the best way to treat them is. And for some people, it's just medications alone. For others, it's open heart surgery or coronary artery bypass surgery, where you go in and have open heart surgery. But there's a segment of people that we can fix with balloons and stents. And once the decision is made to treat with balloons and stents, there's ways of deciding how to fix the blockage. And you can kind of just look at it and eyeball it and say, I think the vessel's about this big, and I'm going to put a stent in about this wide and this long, and that should take care of things. And so you can do it angiographically or just by looking at the images on the screen, and that's worked for decades. But what we've come to realize in the more recent times is that if you use some imaging tool to clearly define the size and length, the width and length of these lesions and the composition of these lesions, that we get better outcomes. And so if we know the exact width of the vessel and the exact length of the vessel and the stent that needs to go in there, and we know the composition of the plaque that's in the blood vessel wall, so we have a better initial result of expanding it to place the stent, then the outcomes are better. People live longer and do better and have less recurrent procedures and heart attacks and things related to their coronary disease. And that is using an imaging tool to get that information, and that's what we refer to categorically as image-guided stent placement.
That's a lot.
That's a lot.
All right. Well, thank you, Amber,
So
for your
that's not
question.
something.
Go ahead.
Ooh, I was just going to say that's not something to be scared of. Then it's more helpful.
It's more helpful. So if you're going to have a heart catheterization and you have a blockage that should be treated, that the physician determines would be best treated with a stent, then using image guidance to place the appropriately sized stent and to assess the success of your procedure using image guidance is better than just eyeballing it and doing it angiographically. Correct.
Thank you.
Yes, ma'am.
Yeah, thank you for your question, Amber. And if you're just joining us and you have a question for Dr. Martin, just give us a call at 318-219-4569. That number is right there on your screen. So we've talked about risk factors and symptoms and the guided thing that she was just talking about.
Image-guided
Yes.
stenting.
So what about diagnosing CAD?
Good question. So if someone comes in and they're having symptoms, they're having chest pain or shortness of breath, and you think that it could be coronary disease, they've got risk factors, and then you work them up and you order a test to try to make the diagnosis. And there are non-invasive tests and there's invasive tests. And the typical non-invasive test is some form of stress testing, where you take the patient and you put some workload on them, and you monitor their heart on an EKG, and you look for any changes, and you assess their performance based on age-matched normals. And so you put them on a treadmill, you walk them, that's an exercise stress test. And those are pretty accurate. And if you add imaging to those with nuclear isotope that you inject in the vein, and the body absorbs some of that, the heart absorbs some of that at rest, and then you give them another dose at peak exercise, and you compare the stress images to the rest images, and you can see they should match up. And if there's gaps or differences between the two, sometimes that means there's a blockage. And so that's a stress test. And if you're someone that can't walk on the treadmill, then we have medicines that we can give you that make you feel like you're running on the treadmill. So we call that the resting stress test or the chemical stress test. And so stress testing is a way. Coronary CT angiogram is a way. That's a high-powered CAT scan of the heart where they take a lot of images of the coronary arteries, and that's probably a little bit more accurate than the stress testing. It's a different way of looking for things, and you get different answers. And so those are two non-invasive ways to assess someone for the possibility of having coronary artery disease. Some people's symptoms are so classic, or their EKG is such, or their family history is such, that your first test is an invasive test, like the heart catheterization that Amber asked about. And so those are the main tests to try to determine if someone has coronary artery disease.
Gotcha. Well, we have another caller on the line. Judy, what is your question?
I had open heart surgery about 8 years ago, but I haven't seen a doctor since. Should I go to a doctor?
Yes, ma'am. I think you should. I tell my patients that coronary artery bypass surgery, it is treatment for coronary artery disease. Like I mentioned earlier, some people are best treated with medicines, some people with balloons and stents, and some people with bypass surgery. But it's only a treatment, and atherosclerosis doesn't turn off just because you had coronary artery bypass surgery. And so the bypass grafts have a certain life expectancy depending on if they're arteries from inside the chest wall or if they're veins from your legs. And so you can have progression of your coronary artery disease or failure of your bypass grafts. And so that a referral for surgery doesn't mean that your interaction with the cardiologist is over. You need to follow up with him after your surgery. And usually we follow those patients serially on through the rest of their life.
Good advice. Yeah. Well, thanks, Judy, for joining us. And if you have a question and you're just joining us, give us a call at 318-219-4569. We're talking about coronary artery disease, and it's a kind of a hot topic. Lots of people. Yep, Leslie's on the line. What's your question?
Hi, I was just calling to see about what Dr. Martin thinks about a calcium score.
Another good question. So a coronary calcium score is a screening test to assess people for coronary artery disease. I didn't mention it earlier when we were talking about stress test and the coronary CT angiogram and the heart cath, but a coronary calcium score is a great test for screening people who are asymptomatic, who aren't having symptoms, or who just have a bunch of risk factors. And that's something that helps us determine the intensity of therapies that they may need, or maybe additional testing. So calcium's an important part of our body. It makes up our teeth and our bones, but it's not supposed to be in our blood vessels. And if it's in our blood vessels, then it's a marker that cholesterol is building up in the blood vessel wall. There's never an instance where calcium's in the blood vessel wall unless there's accompanying atherosclerosis or buildup of plaque, that cholesterol getting in the blood vessel wall itself. And so it's a marker. And so a normal coronary calcium score should be 0. And anything over that means that the process has started. And the higher the coronary calcium score, the greater the risk for an obstructive lesion, a tight blockage. So just having an abnormal coronary calcium score doesn't mean you have a tight blockage. But it does mean that the cholesterol process, the atherosclerosis, has begun, and we usually say under 100 is mild, 100 to 300 is moderate, and over 300 is high. But normal coronary calcium score would be 0. And so if you have an abnormal coronary calcium score, probably ought to see a cardiologist, and or at least, you know, pin down your internist about what therapies you need to begin.
Yeah, good advice.
And what age do you recommend?
Good question. So we went through those risk factors earlier, you know, being a man or a postmenopausal female over the age of 50, high blood pressure, sugar diabetes, elevated cholesterol, smoking history, family history, past childhood body weight, not exercising, you know, 30 minutes 5 times a week. So especially if you've got a strong family history, then a coronary calcium score in your 30s probably has value. And if you have elevated cholesterol and you're in those 20s to 30s, definitely it'd be a good thing to add, just to help the physicians know how aggressively to look and consider treatment of any cholesterol abnormalities.
Well, thanks for the information, Dr. Martin. I appreciate it.
Yeah, thanks, Leslie, for joining us. If you're just joining us, we have a couple minutes left, and you can give us a call at 318-219-4569. So let's say we've diagnosed, and we have someone else on the line. Let's get to Rebecca's question.
Yes, hello?
Hi. What's your question?
I have, my question is, I have an aortic aneurysm that went from 4.5 to 5 points. And I just went through the stress test that he discussed, the chemical. And where they take pictures of your heart, I did all that. And they're trying to decide if I qualify for open heart surgery. I'm 70 years old. I'm a smoker, and I have arthritis all over, so I'm not real active. I would like this. Would he suggest open heart surgery or no?
Well, that'd be hard for me to give you a specific answer on that, but I can tell you, I mean, you shared some good information with us there. Atherosclerosis and high blood pressure contribute to this enlargement of the aorta. The aorta is the main vessel that carries blood from the heart to all the other organs in the body. And when that dilates up, that's considered an aneurysm. And depending on if it's in the chest, a thoracic aneurysm, or in the abdomen and abdominal aortic aneurysm, they're treated differently. And depending on the size of it and the other medical problems, sometimes the only treatment for those are open heart surgery or thoracic surgery to repair the aneurysm. Some of those are fixed. You know, nowadays there's a lot of technology and there's some skilled operators, and some of those are fixed with stent grafts, you know, bigger stents that way bigger than what we put in coronary arteries that we can fix and take people who aren't generally good surgical candidates and fix with these stent procedures. But I would heed the advice of your cardiologist who performed those tests. Sounds like they're ordering the right test, and you know, we're fortunate in Shreveport. We've got a great cardiology, a great group of cardiologists, you know, taking care of the folks around here, and there's really skilled surgeons in our city that can give you a good opinion on what would be the best treatment specifically for you.
Okay, thank you.
Yes, ma'am.
Thanks for your question, Rebecca. And we've got lots of great callers, and if you have a question, we have just a couple minutes left. You might be able to squeeze in one more. And well, moving on though, I did have a question. So let's say you are diagnosed with coronary artery disease and you've already started that atherosclerotic process. Can you stop it from progressing, or can you reverse what's already happened?
Great question. So a lot of debate over that, but there are some studies that have shown that you can. So by getting the cholesterol as low as humanly possible, then there are actually studies that have shown not just arresting the plaque not progressing, but plaque regression. And so that's a very good point to be made. And so the sooner it's detected, an ounce of prevention is worth a pound of cure, right? And so the sooner it's detected and getting the appropriate therapy on, but it's never too late. You can find bad coronary disease, obstructive coronary disease, and with the appropriate treatment and medications, we've seen dramatic changes in the plaque burden that patients might have.
And when do you suggest someone start taking a cholesterol lowering medication?
To be determined. Again, you look at all their risk factors, and you can use a cardiac risk score calculator provided by the American College of Cardiology, where you plug in a patient's specifics, their age and blood pressure and height and weight and all those kind of things, whether they smoke or not. You add all that into the risk calculator, and if they're at low risk, you may just do dietary changes and exercise, get close to your ideal body weight, control their blood pressure and those kind of things. But if they're at moderate to high risk, and based on what their cholesterol level is, you determine if they need to be on cholesterol lowering medications. And diet's important in both of those, right? About diet. And so staying away from fried fatty foods, more fish and chicken than beef, and vegetables. And I tell my patients, if you'll stay on the outside aisle of the grocery store, stay off of those 20 aisles in the center. Eat what God made, right? Eat the vegetables and
anything
those
from
things.
the ground.
Anything from the ground. You're going to be better off than eating all the processed food that man created. So
right, yeah, and soluble fiber and insoluble fiber is really great for lowering your LDL as well, your bad cholesterol.
Right.
So one question that I always love asking cardiologists is, HDL is your good cholesterol. Can you have too much of your good cholesterol? Is that possible?
Yeah, I'm not sure that I'm aware that you can have too much of the good cholesterol, and we've been all over the place with cholesterol. I'm 30 years in, and we've said, let's make the good cholesterol more, and we've looked at all sorts of different things. But the troublemaker is the LDL. That's the bad one. And so there's enough work to be done there, focus on getting that cholesterol down, and we can help a lot of people with a better diet. And we've got multiple drugs that lower the cholesterol. The statins have been a game changer. Some people can't take statins, and sometimes statins aren't strong enough, and they need helpers to get the cholesterol to target. And if you can't take statins, we've got other medicines that have been developed that don't have the same side effects, and they also lower the cholesterol and lower event rates, fewer heart attacks, strokes, and live longer with those. And so it's probably never been a better time to have coronary disease. We got more medicines, more technology, more ways of helping people than we ever have before.
Awesome. Yeah, and so real quick, exercise, you can do strength training or cardio. Is there one that you may recommend over the other, or do you recommend a combo?
So I think for general fitness, a combo is good. Resistance training helps, reduce falls and strengthens our core and does all those things, decrease muscle loss. But it's the aerobic activity that's been shown to reduce cardiac events, and so that's the one we hang our hat on. And it had been 30 minutes 5 days a week or 150 minutes a week, and this past year they increased the recommendations to 300 minutes a week, so 60 minutes 5 days a week. Another way of doing that is, with a wearable, if you do 7,000 steps a day is another way of achieving an aerobic.
And it makes more sense for some people that may not be able to make it to the gym. You can do like 10-minute spurts of exercise maybe throughout the day, get those steps in, in increments throughout the day. So you're not just sedentary all day, you can get up and move.
That's right.
Yeah, great.
Right.
Okay, real quick, website, location, where can we find you? If you have your phone number, share that.
Yeah, I'm at Piermont Cardiology and on the Willis Knighton healthsystem.com, Piermont Cardiology, Dr. Bob Martin, I think it's 212-3858, but I'm not.
If
don't
not, just
help me.
Google Bob Martin at Willis Knighton Paramount Cardiology, and they'll have no problem finding you. So, awesome. Well, thank you for your time. I feel like, this was so informative, especially because it impacts so many people in the Arklatex. So, thanks for your time. And if you missed this, you can catch this on ktbs.com/Healthline3. Thanks for joining us.